So I'm Dr. Cristina Howard. I'm a child abuse pediatrician here in the state of Kentucky. Right now, there's about 4 of us practicing across the state. So what am I? I am a pediatrician, but I've done additional training, so an additional 3 years of a fellowship in child abuse pediatrics. Just like a pediatric cardiologist, nephrologist, it is now a subspecialty of pediatrics because it's been very much needed. I was given the task of talking with you guys about child abuse in an hour. And so your all's packets have a lot of slides in them because I wanted to fit in a lot of information because I think your all's role is very important in prevention and identification of child abuse. So if we don't make it to all of it, that's okay with me. You guys have it as a resource. And so we'll get through what we can today. So what we'll talk about is neglect is going to be the first thing we'll talk about, and then child physical abuse. And I put in a little bit of human trafficking as well. Sexual abuse, I think, could be a whole nother hour-long talk. And so it might be something that I can return for in the future to kind of do as a separate lecture, but I think I try to fit in what I could. Has everybody in here had the abusive head trauma talk? Okay, so I didn't go into a whole lot of detail about that, but I did still go into some of the 10-4 bruising rule, those types of things, because it's so important. Prior to 2015, these cases were all referred to the University of Louisville. I finished my fellowship there and came and started the division here at the University of Kentucky in 2015. We are continuing to build as a team, and so with that, hopefully we'll try to increase our coverage of the state. Right now, we are typically southern bluegrass, northern bluegrass, but we see the rest of the state that comes to the University of Kentucky, and we're available for questions. We help to interpret medical issues and child maltreatment. Anyone can call us and ask for assistance. So I tell med students, families, doctors, lawyers, CPS, law enforcement, anybody, nurses can all call as well. We get frequent calls from nurses. And then we do the formal consults for medical providers, CPS, and law enforcement. Our division currently is 2 child abuse pediatricians, myself and Dr. Sugarman. I don't know if anybody's worked with her before or not, but she's with my division as well, and she's at the Child Advocacy Center. We will have an NP starting with us momentarily. Then we have 2 RNs, an LPN, and a social worker, Wally. So why is it so important? According to the most recent data, there's 1,670 children died from abuse or neglect in the U.S. It's almost 5 children a day. It's an epidemic. This is unreal, and that doesn't even include the near fatalities, which in my mind are sometimes some of the worst. The ones that survive but are neurologically devastated aren't even in this number. Neglect is the most common cause. However, I think that there's a lot of times moms will get substantiated neglect on them. Even though they didn't inflict the injuries, there's a substantiation of neglect because they didn't protect the child. So I think that's what a lot of that is as well. And then, in all honesty, with the opiate epidemic, a lot of times that's neglect when a child has access to an opiate and ingests it and causes a fatality. That's a neglect fatality. Child abuse and neglect, our most vulnerable victims are the ones less than 1. But under 8 years of age is going to be the ones that we need to keep our closest eyes on. They can't tell us what happened. So that's why I always tell families, I'm here because we have an injury in a child who can't say anything. So they're really the most perfect victims. Currently, Kentucky is second in the nation for substantiated cases of child abuse rate. And I think, I'm trying to remember what the number 1 state was. Somebody in the Northeast, it wasn't Mississippi or West Virginia, which is usually what those other ones are, but so we're second in the nation. 2007, we were first in the nation for child abuse death rate. That's a horrible place to be in, but I think it really prompted a lot of people in our state to recognize that this is a huge problem. So more children die under circumstances of alleged maltreatment between 0 of 1 than all accidental causes of injuries combined. And then again, neglect is the most common type of maltreatment, with roughly 59% of substantiated victims of maltreatment or neglect. And child neglect is really a very challenging diagnosis because it's a spectrum. I think when I gave this talk last time, one of the questions was, okay, so we know like roaches in the house, so at what point is it too many roaches? And I think sometimes that's a hard question to answer. I think that when it's putting the safety of the child at risk, if it's in the food, if it's biting the children, that I think it crosses the line. And so there's really not a clear threshold of when a child is neglected. And so again, it's across a spectrum. Physical abuse leaves the signs. Yes, you can spank a child in the state of Kentucky, but it crosses that line when a mark is left on the skin of the child. Neglect, again, it's very hard to say, how often should a kid have a bath in a month or in a week? Or how much clothes do they have to have? Common forms of neglect, we'll talk about physical, which is probably what is one of the easier ones to define because that's a lot of the failure to thrive babies. The medical ones, environmental, educational, supervisional, and then emotional and psychological. And I think that is emotional and psychological is probably the most underreported form because CPS really, they can't take on all of those. That's the mom that you see at the store cussing her child and saying, calling them names and everything like that. CPS can't take on all of those additional cases. And so physical neglect is a significantly prolonged cessation of appropriate weight gain compared with recognized norms for age and gender. We all have the growth charts. We all work with them on a regular basis. And so following those growth charts is very important. We'll look at a few, but if a child starts to drop more than 2 percentiles, more than 2 lines, then that's where it needs to start to be questioned about what's going on in the home. And it's often not just inadequate nutrition, but there's psychosocial neglect to it as well. When we see a lot of these failure to thrive babies, they're significantly developmentally delayed because it's not just I'm not feeding you, it's I'm leaving you in a crib all day. And so they don't get that other stimulation. And that's how a kid learns that when they make a noise and they get that positive feedback, that's how they learn, oh, this is a good thing, and keep making those noises and keep learning things. So without that stimulation, kids don't do anything. And then adequate feeding is not always sufficient to resolve the issue. Nurturing is a huge component to it. And I think that resilience in child abuse is the most important key to that is whether or not they're placed in a nurturing environment. That's how you overcome this. And so the failure to thrive, the 2 most commonly used criteria is less than 2 standard deviations below the mean, or they cross more than 2 major percentiles. And you guys can read that. Other special considerations, we know that it's normal for a newborn child to lose 10% of their birth weight, but we expect them to gain that back by 2 weeks. And so if you have a child under 2 weeks of age that's below their birth weight, have them come back and make sure that they're still regaining. And that's not come back 6 months from now or 2 months from now. It's come back in a week, let us recheck your weight and make sure that you're going on the right curve. It's not strictly categorized as organic or non-organic. They can overlap. One of the examples for that is, if you have a kid that you're concerned for Hirschsprung's, and so that at that point, that does increase your caloric intake, but if you're not feeding the kid, period, they're still not getting any of the calories that they need despite having an underlying medical condition. And I'll show you a picture of a kid that had respiratory issues, but she just wasn't fed either. So failure to thrive, secondary to inadequate caloric intake can be intentional or unintentional. I think this is one of the key places where you guys are very important, is parents that really don't know how to mix formulas. How often are you supposed to be feeding a baby? Those types of things. I am a physician, I'm a pediatrician, but I am a mom as well. And honestly, I've said being a mom is one of the hardest things I've ever had to do. When I would ask my parents for advice, and my dad made me really mad one time because he was like, well, you're the pediatrician, you should know. And I was like, but being a parent is different than being a pediatrician. And so if we can give anybody help in being a parent, that's what we're here for. It takes a community. Diluting the formula they don't realize that there's a significant risk to diluting the formula. They're trying to get to the next WIC appointment or to the next paycheck to buy that formula. So if they just dilute a little bit, that'll help prolong the need for a new one. And formula is very expensive. Social issues, maternal depression is a big one. Maternal-child interaction. A lot of times when I have failure to thrive babies, my recommendation is that I think that they should get an evaluation for the maternal-fetal bond, because there was a break in that at some point, and that's one of my concerns. A lot of the questions to ask: one, what is a child being fed? One of the kids later, mom was like, well, I was trying to give the baby banana pudding because I thought I needed to fatten her up some. And the kid couldn't even roll over yet or hold her head up. And so the baby had significant aspiration pneumonia because mom was sitting there giving her pudding. She thought if she just put food in her mouth and closed it, that the kid would swallow and that was okay. And so it's important to delve into those questions. How is the formula being prepared? Are they using powder? Go down to, so how many ounces of a bottle are you making and how many scoops of formula are you putting in, to make sure that they give you that information. And then, like that one mom that I just told you about, she knew exactly how you're supposed to mix a formula. She knew how often a thing of formula could last, and she knew how expensive it was, but she still wasn't doing any of it. And so I think that's even concerning. When and how often does a child feed? Do they, they say, 6 ounces every 2 hours, which is what I get a lot, and I know that that's not the case. However, it's also important to delve in. Okay, do they do that at night, or do they wake up? Well, no, they sleep for 16 hours at night. Well, that's concerning. They shouldn't be sleeping 16 hours. And so delve into all of those questions. And then the vomiting afterwards. Do they have a lot of vomit? And a lot of parents say, yes, they spit up everything. But one of the things that I learned in residency I thought was very important is when a child does spit up, if you have like a regular 8x11 piece of paper and the vomit is about like that, that's 1 ounce of formula. So if somebody spits up and it spreads out, this is about 1 ounce of formula. So if you put 4 of those together, that's like a 4-ounce bottle. And so that could be a question to kind of figure out how much a child is actually spitting up. So this is the kid that I just told you about. Kentucky has a lot of very significant neglect. This kid and another neglect child came in within a week of each other. This was a near fatality. She ended up being intubated in the PICU because she coded at home. And this mom said that she was feeding her 6 ounces every 2 hours. This was the same mom that gave her banana pudding. And I don't know, is there lights that we can dim? Because I don't think people can see those very well. So she is 8.5 months old and weighs 6.5 pounds. And so the first thing, of course, I do is I look at where she has been and what her growth was. And so, of course, I get all of the records. And you find out that a lot of times when they're this severe, parents will shop for physicians. They don't keep a consistent one. So yes, we've had to call the PCP that she told us about, but she's also gone to the health department. She's also gone to WIC. She's gone to 3 different ERs for certain things. And so each person has like one weight here or there, but nobody has one trend to be able to look at. And so she got up to 9 pounds, and then she dipped. She went back down to her birth weight, essentially. And so that was one red flag. 2, she coded. She came in with respiratory distress, and she had significant aspiration pneumonia because of what she was being fed. And 3, she is a Down syndrome baby. And so she had some heart issues when she was born that never got followed up. And mom would always keep saying, well, I had these concerns, but she never sought care for any of them. And so there was a lot of red flags. And she even had pressure ulcers, one at her sacrum, but then also up here from where her ribs were protruding so much. She, at this point, wasn't opening her eyes. The only thing she had done was that she was sucking on her thumb. She is still in the hospital. She's doing better. And she's opening her eyes, and she's actually interacting more now and doesn't want somebody to leave the room. And so she is doing better. We're still working on growth on her. And so that leads to this other question: has there ever been a period of time where they've had adequate weight gain? And that's where I love to get the growth charts, and I plot them myself and see where they've been. And then what was different then? And we have another case that I'll show you as well, is that they were living with the grandparents up until about August. And then after August, until she came to the hospital, she had lost weight. And so they'd moved out, and mom and dad were living on their own at that point. And so that's one of the questions that we always ask is, has there been a recent change in the household? Have you moved recently? Anything like that? And this is true for neglect and physical abuse. And then, does a child have any underlying medical conditions that might explain it? Yes, this child had respiratory distress, but I think it was secondary to the force feeding. And it may have contributed to the weight loss. However, she just wasn't getting fed, period. She went through significant refeeding syndrome. And actually, she went on a neck watch. Does anybody know what neck is? It's necrotizing enterocolitis that we see in newborns in the NICU. And so we were concerned for that with her as well. And so another example that we've had, anybody from Laurel County in here? Okay. So Cumberland region, we get a whole lot of neglects from. This was a twin that came in. Social workers went to the home they were involved with the case because of maternal substance abuse at birth, went to do just a check on the home, and walked in and saw this baby girl laying there, not doing really anything. So they told mom, they said, you need to get her to the hospital. Just coming in within a minute of assessing this child, said you need to get her to the hospital. I don't think it shows up in this picture nearly as much as it did in person, but her head circumference had gone from here all the way up to here. And she had an underlying medical condition, hydrocephalus, that caused her head circumference to increase. However, mom and dad didn't do anything about it. They said, she started to stop doing everything about 3 or 4 days ago. She wasn't smiling, she wasn't eating. This was the one that they would drop formula onto her tongue and make her swallow it as well. She was another one that was getting 6 ounces every 3 hours. And even when you confront them and say there's no way she was getting that, yeah, she really was. I don't believe it. She also had bruising to both of her hips. And then this picture has too much light in it, but there's 3 bruises to her forehead as well. She was not doing anything that could have caused those bruises. Natural mom reported, she's had a cough. I was getting ready to take her to the doctor, but just never really made an appointment or anything. And they really just I think she was just saying that. And so this was her weight that I was talking about. And so this is when they moved out in August. And then this is when she presented to the hospital. And so it was essentially a straight line across. And the arrows are correcting for her gestational age. But she was growing along the growth curve while she lived in the grandparents' environment. However, when they moved out, she essentially stopped getting fed. A lot of the other things that's important, just as I always say that you can do a lot of a physical exam by just walking in a room. I feel like you can do that with just evaluations of families in general. How is the mom interacting? Are they actually like a hands-on type thing, helping you, hold the baby, change the position of the child, those types of things. In the hospital, I've had a mom call the nurse in so that they could come and bounce the baby in the rocker while mom slept. Those types of things are red flags to me. We had a baby that was coding while mom and dad were making out in the corner of the room. And those interactions are very important to document if there's anything like that that's kind of abnormal or just really gives you guys an uncomfortable feeling, because I do think that it gets important in the future. And they help establish really the big picture of what's going on in these families. Best approach a lot of times is going to be admitting to the hospital and seeing if they gain weight with food. There used to be a multi-million-dollar workup for these kids, all the labs that we used to do, those types of things. But ultimately, if you admit them to the hospital and actually feed them in a controlled environment where you watch for refeeding syndrome and they gain weight, then it really doesn't matter if they have underlying conditions. You're feeding them what they're supposed to be and they're gaining weight. That's proof enough that they weren't getting what parents said they were getting at home. A lot of times it depends on how long they stay in the hospital. And so I will a lot of times do very frequent weight checks on these kids when they go home. Either if we can get somebody in the home or to get to the health department or a pediatrician to get frequent weight checks on them. This was the Down syndrome baby that when she came into the hospital. So she really had started decreasing, but again, this was at 3 different facilities, so nobody saw the trend. And then when she came to the hospital, and I know you guys probably can't see that, this is where she was. She wasn't really even on the growth chart hardly. And when I did her weight for height, I couldn't even do it because it was below the growth chart. And then after 4 days of being in the hospital, she dramatically increased. This is another failure to thrive baby. And what I like to, when I go to court, a lot of times what I'll say is, to give the example, this is a 50th percentile for a 2-month-old. So a 7-month-old weighed 9.8 pounds. That's what a 2-month-old should weigh. The last baby, 6.5 pounds, isn't even the 50th percentile for a newborn. And so I think that that's something that really helps juries as well. And then you'll see in a lot of the failure to thrive, when you don't have nutrition, your immune system isn't as good. So they're at risk for infections. They will typically have thrush. And so you see thrush here on this child's neck, and it gets oral and rectal as well. And then this child was in a bassinet with just a plastic mattress and just left there. And so this was just from sitting in urine on the plastic for so long and not doing anything. She was put in a safe environment, and she looked like that within a month of being put there. And so that's the difference of what we're seeing, which is amazing. Just want that to continue, for her to still continue to be in that environment. What always worries me is a lot of times families will also see this as an opportunity to intervene, but to use it towards their gain as well. So they want to get money from the state, those types of things, and so that can be frustrating. But there are really good homes that these kids can go to as well. So it's very, very important. Once it gets to me, it's almost too late, and that we didn't intervene enough. And I'm relying on you guys for the history for me to be able to go to court and say, this family was educated 6 months ago at the health department on how to mix formula and how frequently to give it. So they knew, and that wasn't happening. Because that gives me the opportunity to say, this isn't due to education. This is just due to neglect. And so your all's education and documenting that is very important. And it's, for me, I don't want to just substantiate abuse. I want the child to be safe. And sometimes that is going to be back with the parents. I had a mom that had 5 kids under the age of 5 that she was homeschooling. And during the holidays, she forgot to schedule the well child check for the youngest baby. And then in January, still continued to forget because she was just so overwhelmed. And by the time the kid got to the hospital, she was a breastfeeding mom. And so she didn't realize how much her child was not growing. And so, yes, we did get the cabinet involved. But when mom came in for that follow-up, she had her notebook with her. She said, this is what she's been fed here, here, and here. This is the therapy that she's doing. So she really got her act together, and she knew everything that was going on with the child. I think she was just incredibly overwhelmed. And so my goal is not to say, you messed up, we're taking your child now. We want to fix what the issues are. And again, nurturing is important. I think that's one of my concerns with the NICU babies. And a lot of NICUs across the country are changing their setup, because you've all probably been in a NICU and you've seen 6 babies in isolates in one room that parents can come in and visit for a couple hours a day. Well, that's a huge missed opportunity for that maternal-child bond. And so NICU babies are at a risk for that bond to be broken. They're now changing a lot of the NICUs to where the parents can stay with the baby in the NICU. And I think that that's important. Management, again, it'll be individualized depending on the child, but close follow-ups, status checks, food, feeding logs, all those types of things. Parental evaluation of mental health. I very often recommend these families get evaluated at the CATS or CAT. Are you guys familiar with the Center on Trauma in Children? So it's a phenomenal resource that we have here in Lexington, and they cover the entire state. And they do evaluations on bonding, family bonding, and whether or not that they feel that it's a healthy relationship or not. And if it's not, what steps need to be taken in order to make that a healthy relationship. So it's a great resource that we have in our state. Home visits, serial photographs, I think, are important because it helps us and it helps families to see the progress of all the changes that are being made. And so I see these kids in a couple weeks and then a month later, and you can see a big difference in them. And it's not just the health department or a physician or one person that's going to make this change. Social workers can help as well. Developmental specialists, these kids usually have that developmental delay. So I have a very low threshold. I just go ahead and refer them all to First Steps for an evaluation. A lot of times they'll have speech delay or something that First Steps getting in the home is a great thing. And then hospitalization for outpatient failure. You know, we had another one recently that came in. He was like 2.5, and they just stopped feeding him. Mom got pregnant, so she got sick and just kind of left him in his pack and play and stopped feeding him. And he went to an outlying hospital, and they were like, well, here's 3 things of milk, some cookies, all this stuff that they were throwing at him. And he started getting sick. So yes, we want to feed them, but we have to do it safely. Medical neglect is just failure to heed obvious signs of serious illness, failure to follow instructions. And so that's a lot why education always needs to be documented. And I always say, you know, if it's not documented, it didn't happen. And so always document what you tell families. And medical neglect can be fatal in some cases. You know, the asthmatic that's not getting their the breathing treatments, or the diabetic that's not getting their insulin. There was a family in Texas that had a child with diabetes, and they felt that they preferred not to treat with insulin and wanted to pray for it. She died. They ended up having a second child with diabetes. And at that point, the court system required them to treat her with insulin. The parents still refused and still wanted to pray that her diabetes would get better. It didn't, and ultimately the court removed that child from the parents. Because I think that there's a clear evidence that the child needed the insulin. And so chronic disabilities are important. This child, again, and I don't remember why I reposted it again, but I think it was mostly because the medical neglect with her head circumference. She wasn't just a failure to thrive. It was her head circumference and the lack of seeking medical treatment when she essentially became non-responsive. Somebody immediately walking into that home clearly recognized that this child was in serious condition. Luckily, I just found out today that Mom and Dad did plea in criminal court on this, and so they took a plea deal. The potential impact of omission does vary by clinical situations. For example, a completely healthy 2-year-old child misses one appointment or is 6 months late getting their checkup is very different from a child with a lot of chronic issues and severe lung disease, for example, and misses all their appointments. And so again, it's on a spectrum. And what's typically when I talk with providers and there's concern that there's going to be medical neglect, I tell them, I'm like, you need to be very clear with the family about what your expectations are, what the negative outcome is if those expectations are not met, and what you will have to do in that case. And so, does the recommended health care offer significant net benefit to the child is another issue. I think we all probably heard of that case in England of the baby that was born with a genetic abnormality and was non-survivable. Well, the parents, they wanted to seek additional, like a second opinion here in the United States, but the court said that they were continuing on, that was detrimental to the child's health. There was no positive outcome to it. So I think that they actually court ordered for life support to be removed on that child. But it goes both ways as well in recommending, saying, hey, I think this child needs this type of treatment. Is that treatment going to do anything for them? Is it going to improve their quality of life or not? Then I don't know that it necessarily always will in a lot of our kids that have conditions that there's no positive outcome. And I think that a lot of times we'll work with palliative medicine on these cases, and that is an option as well. We have a palliative physician at UK that would do evaluations on children who have a poor prognosis and talk with the families about making educated decision on how far they want to go with care. And then access to health care is another big issue here in Kentucky. And an example of that is I got consulted on a kid for a skull fracture. His twin was pulling him in a wagon. The kid fell off, bumped and fell into a concrete and got a skull fracture. Completely plausible story. When you examine him, all of his teeth are rotted out to the gums. And so we're like, so tell me about this dental care that's been going on. Mom's like, well, he's autistic. And we've been to 2 dentists in the area, but he bites them. And so they refuse to see him anymore. And they won't sedate him because he's a kid. And so she was like, I don't know what else to do. So at that point, I think that this fall was beneficial because then we were able to get them in with peds dentistry. Peds dentistry sedated him and did an exam. But Mom never even knew that that was an option, and nobody in her area helped her to realize that that was an option or referred them up here. So that I don't think that that's necessarily neglect. She tried to get the child help and didn't know of any other resources. And does the caregiver understand the medical advice given? Hispanic population is always one of those populations, or any type of family where English is a second language. But I say Hispanic because they're incredibly nice families usually. And they want you to think that they understand what you're saying. And so you'll be sitting there talking to them and explain something. And you'll be like, do you understand? They'll be like, yeah. And they don't have a clue as to what you were saying. For us, I always talk with an interpreter on these families, especially if it's getting to the point where I'm concerned about a child, that I want to make sure that they understand. And then I say, I spoke via interpreter, and this is what I told it, and this is what the family was told. And again, even when you're doing, sometimes we'll get to the point where we'll have to do written plans. Well, a lot of the state of Kentucky can't read. And so if you have them sign a contract, it's something that needs to be read to them and they understand what they're signing, not just, here, read this. Because some people don't like to let us know that they can't read. And again, just take into consideration all the factors that can contribute to them not receiving medical care. Family support. So I don't know how many times I've heard the thing, well, Grandma said for skull fractures, as long as it doesn't go in and it goes out, you're fine, that it's not fractured. There's a lot of tells out there about what's safe, what's not. Again, co-sleeping. How many times does grandparents say, well, I did that with you and you turned out just fine. People are getting this advice. And so poverty and economic hardship is probably the most common reason for neglect. Lack of access to care. Health insurance, I'm not sure where that's going to go over the next several years. So that's something that's always important. Geographic constraints, which is why I think you guys are very important, is because you guys are there. And that's important. And I think one of the other things is people don't trust the big city. Health departments are there, the region, you're from the region. They trust you guys more. And they don't like to go to Lexington. Language barriers, family chaos and disorganization, like my mother of 5 that really just lost track of what was going on because she was so overwhelmed. Lack of awareness, knowledge, or skills. There's multiple times where, we will do a parental capacity evaluation. I don't, but I recommend it be done on a parent and see whether or not they actually know what a fever is in a kid, and they can understand what that means when a kid has a fever. Because there's parents out there that really don't. There's parents out there that can't calculate, okay, if there's 2 scoops per ounce and I have 6 ounces, how many scoops does that mean that I need? They can't do that math. And so it's important to take those into consideration as well. Lack of trust in healthcare professionals, again, the big city thing. Impairment of caregivers, and that's a huge one, is just substance abuse. We had an ingestion come in that it's kind of a crazy story. Maternal grandmother accidentally activated her medical bracelet. Ambulance came, saw her, she was fine. It said mom was high as a kite over in the corner. They left. Grandparents left the kid home with this mom and went to a wedding. They returned at 9. Mom was passed out on the couch and baby was passed out on the floor. So they picked the baby up and she didn't respond. Finally, like several hours later, they called the ambulance. The ambulance came and it was an ingestion. So impaired caregivers, you don't know what's going on with your kids. Kids are going to get into anything. Caregivers' belief, again with Western medicine, and then child's attitude and behavior. I think teenagers are some of the most challenging ones, especially teenage diabetics. They have the mindset, nothing's going to happen to me, and so I don't need to take my insulin because I'm not going to get, kidney failure in the future because of it or anything like that. It's not going to happen to them. And so ultimately, a parent is still responsible for that kid. A physician's misunderstanding of different cultures. And I say that in that, there's different cultures out there that we have to respect, but that's still illegal in our country. Yes, there's cultures that believe in genital mutilation. It's not legal in our country, so irregardless of culture, that's against the law. And so we have to take it into consideration, but if it's still against the law, it's against the law. Health literacy and lack of it is another important thing. And just, sometimes we all forget at what point we learned what certain things mean. And so talking to somebody so that they understand it is very important. And not to say, hey, there's a subdural on your kid has a subdural. Parents don't know what that really means. And so going through with them and explaining it in a way that they understand. Child's well-being should be first. And I know I'm kind of running short. Whenever possible, families should be assisted in understanding the need for medical care. Oh, sorry, hold on. Use of language translators, and I'm going to kind of go through quickly some of these. Documentation, again, is always very important. Signs of just environmental neglect to watch out for. Soiled clothing or significantly too small or large. Inadequately dressed for the weather. Those are those kids that are just out there in a diaper in negative 30 degrees. Appears listless, tired, with little energy. A lot of times, it's especially important in school-age kids in that their parents' schedule is really off from what would be expected normal for a school-age kid. Their parents don't go to bed till 3 a.m. So the kid doesn't go to bed till 3 a.m., but they have school that starts at 7:30. So if they're coming to school tired all the time, that's something that needs to be considered. Seems emaciated or distended stomach. States that there's no one at home to provide care. And I think that that's a really hard one. At what age is it okay to be left home alone? And Kentucky really doesn't have that, a law for that. A lot of states will say 11, but I think a lot of times it's dependent on the development of a child and what's illegal versus what DCBS will substantiate as neglect. It is can be two different things. And so a lot of times is a child at risk. And, we've seen all those house fires of the kids that are left home alone and can't get out of the home. And so that definitely is something that's concerning. And I was at 11, very much more mature than my brother was at 11, but I'll say that, but he may not agree. But and again, the impact may not be immediately recognized, and it can encompass multiple areas. Again, I think that I'll let you guys kind of go through this, but essentially what it is honestly neglect in babies can have most of the significant long-term detriments. Is because that's when a child's brain is developing, that's when the synapses are created. And so if they don't get that nurturing and care early on, that long-term that's missing. And they found that out a lot in children that were adopted from Russia. and that they could be in Russia in these orphanages, and you could walk in the orphanage and there'd be 50 babies and not a single one of them was crying because nobody ever responded to those cries. And so they found that even if they're adopted into a nurturing home and brought to the United States, that there's still a lot of psychological consequences of that as they grow older. It's especially in kids with failure to thrive, and they're put in a new environment. I'm concerned then that it's going to swing the other way. You have to have a very close watch for childhood obesity. After that as well, they start to be food hoarders. My 3-year-old that we just had, he wouldn't let the foster mom take the plate from him after he was done eating because he didn't think he was going to get anything back. And so it's psychological. And so I think that they do need help through that as well. And so there's many contributing factors that should be viewed as a community issue requiring a community response. So physical abuse, and again, some of this was talked about in abusive head trauma training, but it's an injury by other than accidental means of a child under 18 years of age, which is the result of actions by a parent, guardian, or other designated worker. And one of the things that I did learn as well is it includes the acts of these. So strangling a child, even though you didn't leave marks, that's still physical abuse. Shaking a baby, even if it didn't have any radiographical findings, that's still abuse, or if you suffocate a baby. And unfortunately, we do get a lot of, hey, I saw this person shake the baby, and we do a workup, and it's negative. However, I also tell CPS typically, you know, we have a football player that comes in after a significant hit Friday night after being in the game, their head imaging is going to be negative as well, but you know that they have a concussion. And so we can't always get that on a baby. So just because there's no radiographic findings doesn't mean it didn't happen, and doesn't mean that child's life wasn't put in danger. Again, the evolution of abusive head trauma, it did start, I think most people probably know it as shaken baby syndrome. However, since 2009, we've been using abusive head trauma because shaken baby kind of limited us to the mechanism, and that it's not always shaking. We found that there's a lot of impact. And typically when a child survives, I don't want to call it a luxury, but when a child dies, you have the luxury of being able to see where all the bruises are because you can reflect the skin back. However, when a child survives, you can't do that. And so I've had a child that I've evaluated in the PICU that doesn't make it, and I go to autopsy, and there's blood all underneath the child's scalp because we can't see it when they're alive. And so we can't rule out that there was an impact, one. And then two, there could be impact against a soft surface or a broad surface that kind of spreads out the force, so you're not going to see a bruise. And they actually found a lot of fractures. It's uncommon for a fracture to actually have an overlying bruise from the point of impact. It's the most common cause of morbidity and mortality in physical child abuse. I don't think we even know yet the long-term outcomes of abusive head trauma. Over 90% of these kids are going to have some long-term deficit, whether that's a learning disability when they start school, or if it's being neurologically devastated and not even able to breathe on their own. There's going to be some type of defect in over 90% of these kids. And it usually occurs in children under 1, and the reason why you always get that training, why I worked hard on requiring that, but it's because we don't think a child dies from the first time that it happens. We think that it's a repetitive injury. When we did the death study in the state of Kentucky, we found that over 50% of kids that died due to abuse had been seen by a medical provider within 2 weeks of their death and had some type of injury that should have been recognized. And most of those were bruises. And so that's why we do this training. Again, it's very hard because it doesn't take much to be a baby. They eat, sleep, poop, and cry, and that's about it. So I always tell the ER, under 6 months of age, I don't think you can rely on any type of neurological exam on these kids. I'm going to do a head imaging on them. The symptoms can be vague. Vomiting without diarrhea is one of my main concerns. But then you look at it on the flip side, how many kids have spit up the parents call vomiting? And so you have to take that into consideration. I understand spit up is different than vomiting. And so I think it's distinguishing the two. And so a lot of times we do miss abusive head trauma. I had the luxury of having the 20/20 hindsight. It can't get to me until somebody else raises that flag that they're concerned. And these, I think you all had when you did your abusive head trauma training. Again, the mortality rate is 20 to 30%. And what I tell the ER, because they always are like, well, we don't want to do a head CT because of the radiation with it. But how many CTs are done when they're concerned about an appendicitis? Every single person that has right lower quadrant pain is getting a CT. The mortality rate for missing abusive head trauma is higher than that for missing an appendicitis. And so that's why we need to do it, is that the risks of missing it outweigh the risks of getting the head imaging. And then you can get the long-term disabilities. One of the things that I don't know that a lot of people know is the hormone and growth problems that are associated with it. So I think it's very important on victims of abusive head trauma to continue to watch their growth as they continue to grow. And age, I guess, is a better term for that, because their pituitary can be damaged. And so the growth charts, again, are very, very important. And then bruising. Their landmark article is "Those that don't cruise rarely bruise." And that was Sugar and all did that. McGuire, I'm sorry, not McGuire. Now I'm blanking on her name. Did the research on the 10-4 bruising rule. And so the 4 months of age and younger is the specific one. I wanted, all of us in the child abuse world, like, well, what about those 6-month childs? They are becoming a little bit more mobile. And so depending on the location or type of bruise, it's less specific for abuse than anywhere, like the 4 month of age. And bruising cannot be dated. I don't know how many times I get that, well, this kid has multiple bruises at different stages. And that was in some of the old textbooks. But what we have found is you can hit a person at the exact same time at 2 different locations of their body, and that bruise will evolve differently. They will get red differently and greens differently and those types of things. So what we can say is if there's any yellow in the bruise, that it's at least 18 hours old. And so that's always important for documenting if you're looking at a bruise, to say whether or not it's yellow for us, please, because that can help with timing. Here's the 10-4 bruising rule. I do think these are some different pictures than what you've seen in the past, so that's good. So any bruising to the torso, ears, or neck in a child 4 years of age or younger, or any bruising anywhere in a child 4 months of age or younger. The neck is always one of those that really scares me. I see that in a lot of our fatalities. And so always look in that neck, move all those rolls or whatever you need to do to evaluate the neck. And then the other one that I think we forget about a lot is the frenulum, to do an assessment on whether or not the frenulum is intact. Torso, do you guys remember these stories? Or so these are different kids. I think everybody recognizes how sick this child looks. This was a DV episode. The neighbor overheard mom and dad, or mom and mom's boyfriend, I can't remember which one, arguing. And he was like, oh, they're at it again. They fought a lot. So he was just not going to do anything until he heard this baby like he's never heard the baby cry before. And at that point, he decided to call law enforcement. Luckily, in that area, law enforcement was quick to get the cabinet involved on that response, on that call, so went to the home. By the time they got there, mom and dad are like, everything's okay. Yes, we were fighting. We've calmed down. We've stopped fighting. Everything's good. CPS was like, great. I still need to see your baby. They started to get mad because the baby was finally asleep in the crib with the lights off. But CPS still went in, turned the light on, unswaddled the baby, and immediately saw that she was her color was abnormal, and then saw all of this on the abdomen. So she called an ambulance and got the kid to the hospital. She did have abusive head trauma, multiple fractures, a large liver laceration, and a pancreatic injury. If CPS hadn't gone in there and unwrapped her, she would have been dead the following morning. I strongly believe that. This little kid, mom was at work, left with her boyfriend, came home, saw the bruise, asked the boyfriend what happened. He didn't know. And so she decided to take the kid to the ER. Part of me wonders if she had some additional concern, because I don't think a lot of our moms would respond that way. So came to the ER. This kid was evaluated. She 6 months old, sitting there with her pacifier, looking happy, evaluated by a peds resident, a peds ER physician, peds surgery resident, a peds surgery attending, and everything was documented as a normal exam. But we did The abdominal sort, we do have trauma labs, and that includes, abdominal labs, ALT, AST, amylase, lipase. Her ALT was in the thousands, so she had a grade 4 liver laceration that was not picked up on physical exam by multiple people. And so that's why with babies, we do those labs. We screen for those injuries that we can't see on exam. We screen for those fractures that we can't see on exam. Ear bruises, anybody ever had an ear bruise? I always ask that of adults, and I very rarely get anybody to say that they have. The ear is a very protected area, one, and that two, it's difficult to get it to bleed. It just has a poor source of blood to it. So if you're falling, typically you think you're going to hit your head or your shoulder. You have this protective triangle right here. So the ear very rarely bruises in accidental means. We do have an occasional one that can be accidental, and that's very specific. So the kid's running through the room, falls and trips on something and goes ear first right into the coffee table. And when I've seen that, I've seen it just on the helix, so just this part of the ear, and it's not going all the way down the helix. A lot of times it'll have an area of redness, like a linear area of redness associated with it, which is where the corner of the table was. For it to get down in the crevices like this, that doesn't happen with accidental injuries. We've had this story, the helmet got stuck on his head and he got bilateral ear bruising. That doesn't cause that. This child also had a ruptured membrane, so she had blood coming out of her ear. This baby ended up having an underlying skull fracture because she was kicked in the head. So ear bruising is not normal. Again, the neck bruising, and honestly, when I see it, I apologize for the kid up there, but it's pretty severe. Typically, the times that we see it are with abusive head trauma, and so whether or not that's how the child was held or when the chin actually impacted the chest as they were being shaken. And then strangulation. This kid had a potty accident, and as a result, mom's boyfriend got mad and grabbed her by the neck and pushed her up against the wall. She also had bruising on her, overlying both of her scapula on the back. So neck bruising is significant. Always look at it. And then this baby, trying to keep a close eye on time. This baby, when mom had the baby in the hospital ended up contacting CPS. There was warrants out for mom's arrest. She got put in jail. Mom and her boyfriend both got put in jail. So the baby went home with maternal grandmother. Mom's boyfriend got out of jail before mom did. He's not baby daddy, but he wanted to have a night with the baby. And so maternal grandmother let him for some reason. She said she had a guest house on her property, so she let him stay in there with the baby that night. She went the following morning, so the baby was just screaming at the top of the lungs. She asked the boyfriend what was going on. He said, she's just getting sick, but wouldn't let grandma in the house. She left, but came back about an hour later and forced her way in. And at that point, she was like, what happened to her face? And he was like, I don't know what you're talking about. She's just getting sick. Eventually ended up at her pediatrician's office. And this is really the best picture I have. There's a bruise right here. This is thrush and then just a yeast type rash. But she has a bruise right here. And she was so mottled on initial presentation that I was like, is this just like where modeling has coalesced to a little red area? Nonetheless, we did a full workup. The following day, it did look more purplish. And so I thought it was more a bruise. She ended up having 21 rib fractures. And so she looked good, isn't pretty good on exam. And then she ended up, and you can see a lot of these are the healing rib fractures. So you can see how it's kind of circular. Right through here, there's no rib fracture here. Then you can see one there. And then also if you come out here, those are healing rib fractures as well. So she had 21 of them. So that's why we do a workup on those kids. Pattern bruising, I think is one of those. Parallel linear bruising is not normal, especially when it goes over multiple planes of your face. Your plane, the face has multiple surfaces to it. So a lot of times we'll get the history of falling into a rigid object. Well, rigid objects can't conform to your face like a hand can or a belt can. And so that's why a lot of times the parallel linear bruising is diagnostic of being inflicted. It's not from falling, it's from something that's rigid, or it's something that is flexible and can conform to the contours of the face. This I just can't take out because I don't think I've ever seen a more perfect pattern of a hand on anybody. Bite marks, this is probably one of my most memorable cases I've had. The perpetrator on this had been prosecuted for abusing a child previously. Looked very similar to this. Prosecuted in that he would bite the girl's fingernails off, bite her toenails off, bit her face, caused a lot of significant damage to her. He got out on what's called shock probation. Does anybody know what that is? Kentucky and Indiana are one of the few states that have shock probation, and it's supposed to be for people with minor offenses. You don't pay your parking tickets, you get put in jail. It's supposed to shock you into being an outstanding citizen. You get released on probation. It shouldn't be used for perpetrators of physical abuse. I really wanted to show the judge the pictures of this girl, but I don't know who the first judge was. He got out on shock probation, found another mom who had this daughter. And, you know, it's the DV role. He isolated her from anybody, ended up getting mom pregnant. Mom had a baby that was his, and he was scared to hold the baby. So he said, you take care of the baby because I'm afraid to hurt her, and I'll take care of this kid. So whenever the baby would cry, he would get mad at mom and say, well, fine, I'm going to make your baby cry, and take it out on the baby. Or on her. Eventually, one morning, he came and told mom that her arm exploded. And I don't have the picture of it, but what ended up happening was that he had cut her arm. We call him machete perpetrator. People are really messed up. He cut her arm and also caused multiple fractures of her arm. Bite marks are, when I see them on physical abuse, I'm very concerned because they're usually a very sadistic type perpetrator. They're one of the few forms of abuse that overlap with sexual abuse. And I think that a lot of times, I personally have a lot of a struggle with perpetrators of sexual abuse because I think that it's planned, it's manipulative. Physical abuse, a lot of times I think that it's loss of control, loss of anger. However, when there's bite marks, it's so much more sadistic. I have parents that'll say, well, I was numbing them. I was playing with them. Bite down on a kid. Have you seen a toddler bite another toddler? It's not just a light, accidental type of bite. They were meaning to hurt that other kid. And when an adult does it, they know that they're hurting that kid. It doesn't happen accidentally. Again, yes, the most common perp of bites is going to be toddlers. But don't give that history to the parent. When you're going through the history, just say, hey, what's going on with this bruise here? Do you know how that happened? And if they say, well, this 2-year-old in their class at daycare bit them the other day, or a friend, I think is what daycares always say because they can't tell the names. So a friend at daycare bit her the other day and I have the incident report. Yes, I think that is one that's plausible. However, if they have no idea the kid doesn't go to daycare, that should start to raise a lot of red flags. The loop marks, and so on these you can see the loops to them, and a lot of times you can even, I don't know if you can see real close here, but there's a parallel linear component to that loop mark. So that's the width of the outline of what was used to inflict the injury. A lot of times these are some type of a whipping motion, and that's why you get the outline, is because of the whipping. It kind of breaks the vessels there, and you get the petechiae that cause the outline of the object that was used. Most common objects are going to be belts, electrical phone cords, wire coat hangers, fly swatters, those types of things. And then the slap mark. Again, this is kind of, I don't think we usually get that clear of an outline. And this is where I think, a lot of times it's portrayed wrong, even in Hollywood. And I always use the example, How I Met Your Mother? Did anybody watch that? There was this slapping game on How I Met Your Mother. And so they would, they would slap each other really hard. Well, you'd just get the red finger outline on the face. That's not really how slap marks bruise. When I see that red outline, I'm more concerned about a contact type of reaction to the skin. It's more of the outline of the fingers. So that's why you get the parallel linear marks. Usually on the left side of the face, a lot of people are right-handed, but I don't know that I would really make that a diagnostic, like say, oh, if it's on that side of the face, the person's right-handed, because I've seen a lot come up behind a kid too. And so I don't know that that's really too diagnostic. What is normal? Bruising to the front of the body over bony prominences in kids that are really learning to walk, those types of things, is completely normal. This time of the year, I don't know. I mean, my daughter's legs probably look worse than that right now. And so bruising to the shins, those types of things are very normal. And that's even one of my questions that I'll ask when I have a concerning bruise is, where do you typically see bruising on your child? And if they say, well, they always get this ear bruise, well, that's a red flag. However, if they're like, no, I don't think they bruise much, typically forehead, shins, those type of areas. And I'm like, okay, that's normal. The fractures, and this you can refer to, most of the common ones that we see with inflicted injuries right now are the posterior rib or the classic metaphyseal. Scapula and sternum, those take a ton of force to cause fractures to that area. And by a ton, we see it accidentally, like when a person gets hit by a bus or falls from a 4-story window. So that's a lot of impact to cause those injuries. Last time I saw it, I think was a chimney fell on a kid. A 2-story chimney fell on a kid. Posterior rib fractures, why they're so specific, and I don't think a lot of people realize this. We learned this, I want to say in the 80s, when they were doing CTs on some of these kids, and what they were realizing is that the ribs are breaking on the inside, so on the lung surface. And once they started realizing that, then they started to question, so that can't happen from a direct blow to this kid. So what's happening? And so what happens is, so this is the normal orientation of the chest. And when somebody squeezes a child, either when they're shaking them or just squeezing them because they're angry, it causes the ribs to kind of bend back over the spine. And then the spine acts as a lever, and it snaps that bone on the inside. So that's why it's very specific for a squeezing of the chest. It doesn't happen in CPR. We even found that with the thumb change in CPR, now where they recommend on babies where you do the 2 thumb, that hasn't increased posterior rib fractures. So we don't see it with that, and it's unsupported back that you see these rib fractures with. And this is just some of the healing. And from our perspective, on our initial evaluation, yes, we do a trauma survey. The normal trauma survey right now is about 29 images. And so it's multiple views of the chest, multiple views of each long bone of the body, the head, the pelvis, a total of 29 images. And then we have to do a follow-up trauma survey in 2 weeks because acute rib fractures can be very hard to see on x-rays. And then also metaphyseal fractures, which are highly specific, can be hard to see. And kids start to heal in about 10 to 14 days. And that's when they get what I call this big calcium ball around it. And I think most of us that are close enough at least can see that that's a lot easier to see on x-ray. And then it helps us to time. So we typically will do 2 sets of x-rays 2 weeks apart. And this is a metaphyseal fracture. And so this in a baby or in a kid's bone, this looks like this on x-ray because this is all cartilage. So this is the end of the bone, but since it's growing, it looks like it's cartilage and you can't see that on x-ray. So this is the growth center. So it looks like an ice cream scoop on top of it. And then this is the growing center. So the metaphysis of the bone is susceptible to breaking. And how it does that is that you have to have a perpendicular force across the joint. And so I kind of equate it to like a football player that gets sideswiped and kind of goes across their knees, that type of mechanism. The football player doesn't get this fracture because at that point their bones are more developed, and so they don't get these fractures. But we see this a lot in kids with abusive head trauma when their arms and legs start to flail, and so you have that acute dramatic force change in force. So as they're changing positions, it can cause that fracture. or if you have a kid kind of laying on the changing pad and you swipe them up angrily across their joints, that causes that type of fracture. They're very specific for abuse. We don't see them in accidents, especially in babies. And then multiple fractures. My general rule is that if a child less than 1 year of age has any fracture anywhere, I'm going to do a trauma survey. This kid was 2 months old and had some redness and swelling of her right tibia, or of her right lower extremity. Went to another hospital, they found a spiral fracture for tibia. Once we did the skeletal survey, she ended up having 26 fractures. A lot of those were in her feet, and so that kind of made an increase in the numbers, but that's a lot of fractures. So under 1 with a fracture, I'm going to get a trauma survey on. And then this kiddo was a 13-month-old that mom's boyfriend just said she was unresponsive. And her skull just looked like a broken egg. She has her cerebellum ended up getting a little injured, so more of her brainstem. So she has some balance issues, but she's overall doing a lot better. Burns, and one of the things that's always important to me on burns is going to be early pictures. A lot of times what we want to know is the first degree component to it. And so this baby down here, this is the same kid. She was in an outlying hospital. By the time this was when I was at U of L, to U of L, a couple hours later, that first degree burn didn't look anywhere like what it did on presentation. Luckily, law enforcement took this picture. And I think she looks so pitiful there, and you can clearly see the immersion pattern to that. And so that's very important to get burn pictures early. I always tell my ER, I'm like, before plastics gets involved, before you wrap it, please, let's get pictures. Because it's very important in these criminal cases. Pattern burns, and then circumferential burns are always important. And burns to the genitalia is not normal. And do you guys still do a lot of the education about hot water heaters? This is why. And so at 120 degrees, which is the recommendation, it takes 10 minutes for a child to get a second degree burn. Well, actually, this is based on adults, but for children, 10 minutes to get 120 degrees burns. By the time it gets up to 150 degrees, it only takes 2 seconds for a child to get a burn. So that is why, we had one recently this family was renovating this old home, and they did some of the plumbing in the bathroom, and so they took some PVC pipes and they did the glue and glued it together. This kid was in the tub, and I think he was playing with a water bottle and started banging some of the piping, and it broke apart. And when it did, it started coming out on him, and he got significant burns on his face. And then when he stood up, it went all the way down his body. When they went, the hot water was 170 degrees. And so the pipe that he broke was the hot water side. And so at that temperature, that's enough to melt the glue that was used anyways. So I think that was just waiting to happen. And so please keep doing that education on 120 degrees. To set the hot water heaters. It's very important. What can we do to help prevent? Thorough skin exams whenever possible. Make a report to DCBS whenever you suspect. Our state does have laws that protect the reporter. It's very rare for somebody for a lawsuit to actually go through if there's legitimate concern. I'm not saying there are people that would do vindictive reports. Like, you got me in trouble, I'm just going to call and report something on you. Those, I think, are harder, but if you have a concern, then we need in our state to report that. Don't be scared to share what you learned. Document. Pictures, all those are important. Briefly on human trafficking, essentially most of this is in your document, but what I wanted to say is that human trafficking is a deal here in our state. One, with the interstate system, there's a huge system with truckers and human trafficking. And then two, whenever there's events, so like the NCAA tournament, the Derby is a big one, that human trafficking becomes a whole lot more increased. And children are a lot of times the victim of these, and that's unfathomable to me. It's a multi-billion-dollar industry. that there's actually demand out there for that. It's starting to increase too, because dealers are starting to realize, hey, with drugs, once I sell that, I have to find another source for drugs. So I have to keep getting something. However, when you have a person that you can use over and over and over, you don't have to reinvest in anything. And so it's starting to become a huge problem. And I think a lot of them go to health departments for STI treatment. And so keep your eye out for the tattoos, the behaviors that are listed in your handouts. And so a female that comes in and isn't allowed to really talk for herself or provide the history, or a male that won't leave her side, those types of things. It's important to try to get some type of separation so that you can ask some of the questions that need to be asked. And it's not just, hey, are you being trafficked? They're not going to say yes. It's, starting into the details. Hey, what does that tattoo mean? Or have you ever, and it's not going to be upfront. It's not going to say, have you ever gotten paid for sex? Those types of things. I think that automatically is going to shut somebody down. But just try to do it bring it up in a conversation that's one-on-one with them, and to notice those red flags. And one of the hardest things about victims of human trafficking is they don't like to admit that they're victims. And so sometimes we do have to advocate for them, and sometimes we have to just provide them with a resource. And so say, if you ever need to talk with anybody, please come back. We can schedule a follow-up, those types of things. But I think they like to use the health department to get in, get their STI treatment, and get out. So keep your eyes out for those types of things. Is there any questions? I know I went over a little bit. Okay.